All right, good morning, everybody. I'm going to call our Subcommittee on Behavioral Health to order. Madam Clerk, would you please call the roll?
Chair Braybeck.
Here.
Representatives Arbit.
Here.
Pohutsky.
Here.
Glanville.
Here.
Edwards.
Here.
McDonald. Reingens. Schmaltz.
Here.
Hoadley.
Here.
St. Germain.
Here.
Thompson.
Present.
Madam Chair, you have 9 members present. You do have a quorum.
Thank you, Madam Chair. I know that Rep. Reingens is here, but everyone, thank you for your patience as we dealt with unavoidable traffic. And so I appreciate everyone being patient so that committee members could get here. Thank you to everyone who is here as well for your patience. Let's do some housekeeping. Vice Chair Arbit moves to approve the minutes from our March 2nd. Seeing no objection, the minutes are approved. And then we'll wait. Should we wait for until the end? That's great. So we were a little bit interrupted because of a variety of reasons, but glad to be back with you all. We have our presenters who were here with us last time. So we have Alan Bolter, Trish Cortez, and Lisa Williams, all here because we didn't get to ask all of our questions. We got a couple of questions answered, but they have all graciously agreed to return and answer questions so that we can dig down on CCBHCs and any questions you have on CMHs as well. I'm assuming as folks are also getting used to all the acronyms. So I would love to have the three of you come up. And Alan, did you want to talk about this since that was a question, get us started with that? Or did you want to wait on that?
Yeah, if you want me to talk
great.
a couple minutes on behavioral health homes and opioid health homes,
Thank you.
Happy to do so. I foolishly didn't keep a copy of that for myself, but I think I'm all right. I don't need it. So there was a question in kind of my overview of a couple of the exciting models that are happening in our public mental health system. You know, we had presentations on CCBHC, and you'll hear more of that. The other one is the health home model that we have going on, and those primarily exist in thank you very much. Those primarily exist in northern Michigan and in the Upper Peninsula. They're a little bit different model where the CCBHC model really eliminates the prohibition as far as who's eligible for services for community mental health, where it opens up the door to everybody. The health home model really focuses on those individuals that only qualify for CMH services, so really focuses on those individuals on Medicaid, and it's really the theory behind it would be those individuals that are probably more of the frequent users of services, more of the high-end, high-cost type individuals. If we give them more money, services, attention upfront on the prevention side of things, where they actually have a designated caseworker that works with them on the front end to help coordinate some of their physical health needs as well as their behavioral health care needs, and they get a special payment to do more intensive case management on the front end. That actually saves money on the back end. You see less hospitalization, they show up for appointments, they do better taking medications and things of that nature. So it's a little bit more confined on who's eligible, so it's someone that actually qualifies for CMH services, but they've had great results in northern Michigan on that. I think there's probably on the health home side, a couple thousand people or so that are in that program now. On the opioid health side, there's probably 3,000 or 4,000, but they all have had the data that's come back. They've actually lowered the healthcare curve for costs. They had reduced hospitalization. As I said before, they had increased, participation with their medication, showing up for appointments, things like that. So it's a slightly different model, but really has worked well up there. And it's probably one of those, are one of them better than other? I think they are both working out very well, and it's another example of on the ground, if we coordinate care for somebody, you're going to see their health outcomes improve dramatically.
Please.
If I could just add to the health home conversation, so in Washington County, it is not a either or. It could be a both and. And in Washington County, we are also a health home. And so for us, what that means as a CCBHC is that everyone qualifies to be part of our health home. And we do very targeted, data-driven focus on individuals who are serving, which now includes the mild to moderate, but that might have some really deep-end physical health care needs. So we are able, through data, looking at emergency room visits, inpatient hospitalizations on the physical health care side, doing very targeted physical health care coordination. So I just want to make sure it's clear that you don't have to be one or the other. You can be a CCBHC and also a health home.
Thank you. That's a really important clarification. So we have some questions. Please let me know if you have questions, but the first question that we have is from Rep. Thompson.
Hi, good morning. Thank you so much for everything that you do and for presenting last time we were here, and is for coming back as well today. So my question is actually for your intake process on after hours around the weekends. If you could maybe walk us through what it would look like if someone were to seek services, say 10 o'clock on a Friday night.
Sure. So if someone were to call in the traditional after hours, they would still be able to receive their screening. They would still go through the process of their assessment. They would have the option of doing the assessment at that time or deferring until later in the week. If it was a crisis situation, they would immediately be offered opportunities for 24-hour mobile crisis, which includes access to a therapist, a peer, a care manager, and a psychiatrist if necessary. If the crisis is able to be resolved, they would automatically begin that process of their intake kind of paperwork and process for their assessment. So they wouldn't have to necessarily repeat all the things when they came in for an actual assessment, say on Monday. So we really take every point of entry, no matter what time of day and night, as sort of the beginning part of a start to a care process. If it's a short-term crisis that maybe can be resolved, we still would follow up with the person, but they may not necessarily have interest in entering long-term care. But we would still, long-term services or entering more formal system of care with all the full array. If that was the case, we would still follow up and ensure that they had been connected with whatever resources we had recommended at that point in time or that they had requested at that point in time.
So when you say mobile services, so you would go to the individual?
You absolutely would. That's one of the requirements of the CCBHC model is that you can go to the person where they are. Obviously, you have to make sure things like safety are addressed and concerns around safety and things like that. But no longer do you have to go to the ER to access services on a after hours kind of basis. We can come to you in your home. We can, if you would prefer, we can come to you via telehealth. If you would prefer, we can meet you in another community setting. We could meet you at the school. We can, all of those. Obviously, probably not 10 o'clock on a Friday or Saturday night, but wherever is most appropriate to you, that's where that mobile crisis teams.
Psychiatrists on staff.
We have psychiatrists on staff. They don't, and they're available on call for that mobile crisis team. So if there was some sort of a need for
medication,
a consultation,
that's I was looking, would they be able
or
to
medication,
get?
those kinds of things, you would have that access. Yes.
Okay. Thank you.
Yep. And just one of the things that folks have sometimes said around mobile crisis in the rural communities, it is expensive. It's hard to staff it because you have a large geography. But the value of it for connecting people when they need you, when they want you, where they're at, when they're in the point in time where they're actually seeking services, and being able to make that relationship in that moment is really critical to engaging them in care and long term. So it's a costly element of the model, but I think in the long run it's going to save us on inpatient admissions. It's going to decrease the likelihood that somebody's sitting in the waiting room It's going to create lots of other opportunities for folks to connect and engage meaningfully with people at the point when they need us.
Rep. Reinkens.
Thanks, Chair. So my questions revolve a little bit around explaining some of the processes where you internally in the CCBHCs, health homes, CMHs, would determine how a patient might be served based on their payer. So when I worked in the department and when I worked in the community, it was very confusing to the general public. Hey, I hear that I have community mental health. Why can't they serve me? I have really good insurance through my job. It's very confusing for the general public. And so what we're talking about today is Medicaid programs, but the beauty of what CCBHC allows is since it can serve all people regardless of their insurer, I'm just wondering how you internally, where is that part of the screening? You don't talk about insurance as the very first thing, do you? Or how do you do that? Can you explain that? And then I have a totally different follow-up question.
Just like with any healthcare appointment, we do gather information about folks' insurance. I mean, at the point of a particular crisis, that's probably not the first thing we ask folks, but early in the process of care, that is something that we determine. One of the things that we've done as a result, first of all, your understanding is correct. We accept if you need mental health services, regardless of your payer, we provide those services. So Medicaid.
As a CCBHC.
As a CCBHC.
So only the
correct.
places where there is a CCBHC can this happen, unless people travel from across the state.
Yes, correct. So, well, some of our CMHs also serve folks with private insurance, but they're not under the same requirement to do so. So we gather that information early in the process, but your level of care, the services you received, are based on your level of need and your person-centered plan and your desire for services and evidence-based services, not based on that payer. We can talk a little bit about how that works on a payment end on a different day, because that's a really long story. But one of the things that we did as a CCBHC in order to prepare for that when we launched even in the grant phase was we started recruiting different staff, because some of the private insurance payers don't do reimbursement on if you're not an LMSW, if you're an LPC, or different kinds of credentials different insurers pay or won't pay. So we made sure that the staff we recruited had the appropriate credential to provide services to folks across insurance types. So that was one big piece of addressing that. The other piece is we got on all the insurance panels right away for all the insurance providers that were predominant in our 3 county communities. So we got our staff credentialed and paneled on those different insurance plans, so that even though we can't bill all the services that folks receive in the CCBHC to insurance, those that we can, we bill that insurance first. But that is never a reason not to provide the medically necessary, therapeutically appropriate services to those folks in the CCBHC.
That's an excellent question, Representative. Thank you. I think that there's a false notion out there that because someone's on Medicaid that they have some dismal benefit. As you know, we talked about last time we were here, actually the Medicaid service array is much broader than what my insurance, for example, covers. Much deeper and wider breadth of services are available, like peer supports, case management, the list goes on and on. It's a very narrow benefit for private third-party insurance. The beauty of CCBHC is that everyone, and yes, we check to see what insurance you have and what we can bill, but it really opens up a much broader service array for anyone who's seeking mental health services, and we are able to provide medically necessary services for all. And that is I think one of the most signature, beautiful things about CCBHCs, and it's one of the things that I think have been super frustrating for the community who's trying to say, like, why can't I get CMH services? Because we've had to say no. We've had to say no because you don't have Medicaid, you're not severely mentally ill. Now we can say yes to everyone, regardless of your insurance and regardless of your acuity. And so that's really why we're here today is because we can't stress what the value of CCBHCs are enough.
And then the follow-up, to this and related is when you say everyone, you're including uninsured because the way that the demonstration works, the federal government is providing payment, a little bit of an uplift to help offset the cost of providing care for people, even if they're uninsured. So truly everyone can receive services from CCBHC, even if they're uninsured, right?
Correct. And actually, one of the really interesting things in our community is some of the biggest uptick in volume for us has been in that private insurance population accessing the services. And I think I mentioned last time we spoke that that availability, not just of the typically authorized private insurance services like nursing, therapy, and psychiatry, but now you can have case management. Now you can get housing supports. Now you can get community employment. Now you can get assertive community treatment if that meets your level of need. And that absolutely has been one of the biggest increases in our patient volume has been from folks in that population who've had unmet need for a long time. And it's one of the things, honestly, that has been probably most engaging with our community because they don't see us as only the provider of Medicaid services, and they're seeing that that's a much richer composition of services, as Trish suggested. So, yeah.
And then my totally different topic question is around the new 988 phone service. So previously in the U.S., there was a suicide hotline that had a full 10-digit number, and we would hope that people could remember that if they needed that in a crisis. Now we've changed this in Michigan and across the country since last summer to 988 instead of 911. And I'm curious, it's not even a year old yet. I'm curious how you're interacting with that, with referrals into your crisis services in these CCBHC areas, and how is that interface working?
It actually has been fantastic. I was a little skeptical. We have one phone number, which is crisis. You can call because people are looking for housing, or you can call because you're in crisis. It's the same phone number, 544-3050. 988. If someone calls 988, at the MyCal is the system that's working it. A worker will screen that call, and if they deem that they actually need to deploy, that is a crisis type situation, they will do a warm handoff to, for example, my crisis workers, and say, "We got this call. We need you to be deployed." So 988 actually will result in a direct deployment from the local CMH. Now, not all CMHs have got mobile crisis teams. We do because we're CCBHCs. And there's others that are not CCBHCs that also do mobile crisis, but we have to. And I can't tell you enough of the value about that. But 988 is it's another way just to access us.
Rep. Glanville.
Thank you, Madam Chair. And I think my question was largely answered with Rep. Reingans. I was concerned about cost. But I just kind of want to clarify one final time for myself. So if the cost of your coverage depends on, or the cost of your care depends on the type of insurance coverage that you have. So is that, that's how it works, right? The patient, I'm sorry. As a client, if I'm going to access a CCBHC, at the end of the day, how I pay you for the services. It's free to me.
No, go ahead.
Yeah.
Okay.
No, we do not bill patients.
No, but you bill the insurance company, and then I pay. I'm sorry.
Right.
I would pay my insurance company for those services.
So if there's Blue Cross Blue Shield
Right.
comes in through our door, we would pay for what they cover. So that
Right.
just would be psychiatry,
Got it.
et cetera. The others, but that individual, that patient, would be eligible for other services that are not covered by the insurance, and that would not be billed. That would be, we just provide the service, and it's part of what we do as a CCBHC.
And as a client, I would not have to pay for that.
No.
Oh, okay, great. Because I don't know if it's more of an insurance question, obviously, but we have not been giving parity to mental health in our insurance, and I just want to kind of understand that as a client. Because I noticed you said, you might ask about insurance questions but maybe not the first question you ask, but just knowing how stressful financial, positions can be, that's probably one of the things that keeps people from care, right? Is understanding how much it's going to cost them. So thank you. It sounds like a fantastic program.
Thanks, Rep. Glanville. And I actually wrote a note to myself to share with you all after we all met last time. The four of us were talking, and one of the things that is really kind of challenging to understand and to take in is the financial modeling around this. And so we talked about, maybe even coming back and doing a session just on that, on the financial modeling and the viability for all this, because that is in fact what the end user, has to pay or not pay. But there are lots of funding streams and some advocacy that we're going to need to do in order to be able to get CCBHCs continued past 2027. I mean, there's a lot of things that we can do, but I think that could be helpful as well. So, Rep. Schmaltz.
Thanks, Madam Chair. We know access is a big problem. We want to make sure everybody, is able to get help. This mobile access is so intriguing to me. Of course, it's costly and there's a safety issue. How prevalent is that throughout the state? And what could we do to accelerate that and maybe have more mobile access? I think that's so important.
The one piece I want to address about the costliness of mobile access in Washington County, we were on the brink of opening a 23.5-hour kind of like an urgent care center for individuals in a mental health crisis. We were about to open the doors and COVID hit. So then we could no longer open it because it was too much of a congregate setting. It was going to be 6 beds, et cetera. During the time of COVID, and I think there's some silver linings that came out of the global pandemic, but in that we started really bolstering our efforts around mobile crisis. And here we are now, and we are now thinking, like, do we really even need to open it? Because we have been able to be so adaptable and flexible, and have got so many skills in terms of how we resolve crisis in the community that I don't even know if we're going to open that again. We're already looking at, and when you really think about costs, if you're in a rural area where you have to open up several different urgent cares where people don't have to drive 2 hours to access it, then I don't know how much more expensive mobile crisis teams would really be when you are having to stand up bricks and mortars.
Could possibly save money that way. Yeah.
So I think it's worth really looking at to see what's more expensive, even in rural areas. I'm not in a rural area, so I defer to my colleague, but that's, when we were talking about this earlier, I'm like, I'm not exactly sure what's more expensive. So, and to do that, I think that there are some more challenges in like the, more rural areas, but I think that if Lisa's been able to do it, and for us, it's been, honestly, I don't know that we're going to open up what we originally thought we so much needed to divert people from the emergency rooms.
I think I would add that it's a front-end cost. It's not a long-term cost, right? So it's actually more of an investment that results in savings later on things like inpatient and people sitting in waiting rooms for long periods of time. Need lots and lots of diversion of hospitalization occurs during those mobile crisis visits that might not occur if somebody just showed up at the emergency room. So I think that I raised the cost because that's one of the things that initially we spent a significant portion of our grant dollars to build. But now that we've built it, the long-term payout is definitely there. It's worth continuing to invest in. All the CCBHCs are required to have mobile crisis. There are, as Trish suggested, other CMHs that have mobile crisis around the state, some of whom aren't CCBHCs. So I think, and it is a nationally accepted model, which is why it's included as a requirement for CCBHC. So it's evidence-based that it does, over time, reduce need for hospitalization, long-term particularly long-term hospitalization, creates easy pathways into care, creates opportunities for access after hours, all sorts of things like that. So absolutely.
Yeah,
And-
I think that's an area we really need to look at expanding.
Sure.
There was a small amount of money in the budget the last couple of cycles that did allow for some expansion of mobile crisis services and kind of pilot it in certain areas. So that's something that we would, certainly encourage those of you that are also on appropriations to continue to look at that and put some money into that as well.
And the cost is included in the payment methodology that's set up for the state around CCBHC. So it's not, it's part of the model, and it's part of what's included in how that payment is set. So just also so you know, it's not on top of what you're already building as a CCBHC.
Great, thank you.
Vice Chair Arbit.
Thank you, Madam Chair, and thank you so much for being here again. We're talking a lot about crisis care and response to crisis. I want to shift gears a little bit to just talk about maintenance care and sort of long-term needs for different therapies and different treatments. I think there's a lot to be said about folks who need services right away and are in a crisis situation. I know from my own life that I would not be where I am if I didn't have the long-term duration of care in terms of treatment, therapy, which so many of us in our lives, whether we have weekly sessions or biweekly sessions, that maintenance of care is so important as we navigate through the challenges of life. And so I want to understand just a little bit, if you can, how that operates, with CCBHCs. Is there a cap? Is there, what does the duration look like? What is it up to the patient? How is that determined? And what sort of, ability does a patient have to sort of determine their care on? And what does that look like, in the time scale of like years, right? So thank you so much.
Great question. And it's something that, historically pre-CCBHC, since we really served the kind of the more deep end, severe mentally ill population, they almost kind of stayed with us for very, very long periods of time. In Washtenaw, since we became a CCBHC, a lot of the, the increase in access has been more so we might meet somebody in a crisis type situation. There's an episode of care, but then they don't really need long-term, everything that CMH has to offer. What our data shows is that it is very person-centered. So if the individual is willing and wanting to go and receive their ongoing therapy with another community provider, we will certainly do that handoff. What we found in our data is that for particularly the mild to moderate population that we haven't historically served, is that in about 90 days, that individual, we can pass them off to another community provider of their choice. And so that's where that maintenance is. There are, and I'm not going to know the exact mandates in the CCBHCs, and at least maybe you remember, we also have to make sure that warm handoff happens and that individual does not fall off of care. So if we hand off to a community provider, we need to continue to check in to make sure that person is continuing to be engaged. So there is kind of like a safety valve there to make sure that people don't just drop off of care, and that's part of the responsibility of the CCBHC.
Follow up, I really appreciate that. I want to ask just if you can go in a little bit deeper on that handoff, particularly for people who are either uninsured or underinsured, or and what does that look? CMH or whatever. Are there cases in which they're not able to get the care that they need, or eventually are sort of dropped by other providers because they don't have the type of payment necessary?
I think the way that works for us is if folks enter care and they have a lower level of need, but are engaged in our services, we may make a referral to an outside resource if that was what the person desired. Again, there is a lot of that personal choice component that is a part of CCBHC, and it would be a warm transfer, as Trish suggested. But we also have some folks who get comfortable with the person they're seeing. And so those folks we may continue to see at less frequent duration within our services. Again, it is very person-centered, very person-dependent. As long as as long as that medical necessity continues to be demonstrated, we continue to offer those services. One of the things that we did is we also expanded the types of services that somebody sort of in that lower end continuum of need might have, to include more of the peer supports, to include some of the group therapy options, to include access to psychiatry and supports coordination, so that somebody who may not be able to leave or who may not want to leave our services, they can continue to receive the service that they have from us in conjunction with other kinds of supports as well. We would never put someone in a position who had a true medical need for services of like not having access when they left our doors. So that's not how that works. That's not how that should work. And particularly for folks whose insurance might not continue to cover or who might be indigent, we would continue to offer some support to that person in a long-term way as appropriate for their need. So I think it's a tricky balance because you've always got to have that ability to demonstrate medical necessity. But for folks who desire those supports for a longer period of time, we have lots of ways to provide that. Peer services are really, really popular in folks who are in sort of that want that long-term support as part of their continuum of services as well. We also, one of the things, you have to have a warm path, a warm transition into services, but also that warm transition out of services. And always, recovery is not like a flat line. It's not, Trish mentioned this last time we spoke. It isn't like this. It's not like you get here and, you're forever and ever, you don't need treatment again, right? Similar to persons with diabetes. If you don't take care of that, monitoring your blood sugar over time, if you don't do that over time, you will have episodes where you need to have more engagement and more investment of your medical provider. It's true for mental health recovery as well. So there's always also loop back into services, connections that you can make to come back in. And we have processes to support folks who've been in care before having a warm entry into services again. So I think that's a component of that. Like, how do we do that maintenance, right? How do we do that preventive work? How do we build in things like supportive apps like MyStrength so that when you leave services, you still have tools at your disposal? How do we build skills that support people long term? I know that both CNS and the Guidance Center have lots of strategies like that too, so they can talk to you a little bit about that when they speak later today as well.
Awesome, thank you. Just one more thing, if you don't mind. I just want to hold on one thing that you said briefly, which was you mentioned, psychiatry, and I did want to just ask, when you are, whether it's someone's in crisis or not, right? When you have a patient that you're seeing and they're utilizing in-house psychiatry services, and if they are underinsured or if they are uninsured, right? How is that navigated within CCBHCs? And do you help them get that coverage and how? Because especially if you're dealing with someone in crisis, that it needs to be quick, right?
Mm-hmm.
So is your question in crisis or?
Well, both. I just wonder if you are providing, the psychiatry and they do not have, the coverage that is necessary for, to receive medications and prescriptions. How does that work? Do you pay for the medication for them? Do you help them find the insurance to, get them on Medicaid real quick? Or, how does that? How do you facilitate that?
Oh, to actually pay for the medicines.
Right. Yeah. How is the prescription
It's-
paid?
Yeah. So we, in that for a variety of different ways, we actually get a tremendous amount of support from samples. And so we actually provide a lot of sample medications for individuals that cannot pay for the medicines. So we have a whole entire process of how we store them and how we inventory them. And so we in Washington, we do a lot of support with sample medications.
We also, there's a lot of the psychotropic meds have particular types of prescription drug programs that we assist consumers in getting enrolled in so that they can receive their medications at greatly reduced costs or at no cost. And we continue to work with them to do that. We have also built enrollment specialists in our services that can work with folks to help connect them with different kinds of insurances during enrollment to kind of support those kinds of things. And we have relationships with local pharmacies that really work with our consumers as well to support them in getting that access to medications.
Thank you all for coming back. We really appreciate and answering questions. We may be asking you to return for a financial tutorial for us all.
We'll bring our CFOs.
Yeah, exactly. But we appreciate it. Thank you.
Thank you.
Thank you again.
So now we will be having Michael Garrett. He is the president and CEO of CNS Healthcare, which is a CCBHC. But what I wanted to have folks experience was, we had, Trish and Lisa here, and those are CCBHCs from our CMHs. And so both Michael and Carrie have CCBHCs, but from the provider perspective. So just another way for us to be able to look at this and consider kind of the web of care. So good morning, Mr. Garrett. Thanks for being with us here today. Oh, and I just found out that the building is experiencing some internet issues. So if the PowerPoint goes out, that's why. But we all have copies at our desks as well. So welcome.
Thank you. This is on, right? Okay. Thank you again. My name is Michael Garrett. I'm the president and CEO of CNS Healthcare, and thank you for the opportunity to present before you today. My presentation today is brief because I think my colleagues before me did a really excellent job about explaining a lot of things about CCBHC and covering things, and I would like to put in a very small bit about when you do want to talk about finances. I would definitely love to be part of that. My background is as a CFO, so I think I'd have something to contribute to that conversation. Okay. I'm from CNS Healthcare, and we are a provider of behavioral health care services in southeastern Michigan, Wayne, Oakland, and Macomb counties. We serve about 11,000 people annually, adults and children, so ages 0 to 17, and obviously 17 and above for all ages. We became a CCBHC in 2018 through an expansion grant from SAMHSA, and we are also one of the 13 demonstration sites statewide, and we've been a demonstration since it started in 2021. And as stated before, one of the things that we're most excited about for CCBHC is that we're able to reach a population that we never would have been able to reach before. Quite frankly, we have more people coming to our doors, and oftentimes than we have the capacity to serve due to labor shortages and trying to find the appropriate talent in the system. But we've been able to transform the lives of everybody that we've been able to see. Because CCBHC allows us to service people regardless of their ability to pay, where they live, their insurance status, or the severity of their illness, being able to see people in the mild to moderate space has truly been a game changer. I'm sure a lot of you are aware how the current public mental health system is structured. In order to be able to gain entry to that system, you have to be what's called severe and persistently mentally ill. If you do meet that criteria, you're able to get a plethora of behavioral health care services that can pretty much service whatever type of need that you're presenting with. However, if you don't meet that threshold and are mild to moderate, 90% of what I provide as an organization, quite frankly, is not available to you. You can't get it on the secondary market. You can't go and find an ACT team or sort of community treatment team in the community.
Mr. Garrett,
yes.
Can you explain an ACT team?
An assertive community treatment team is a team that, for someone that has a high degree of behavioral health care need, this team is dedicated to you and to your health care, and they see you several times a week instead of maybe the more once or twice a month type frequency. So they go to your homes, they go to your job, they'll meet you at the neighborhood McDonald's, convenience store, wherever you are, to make sure that whatever behavioral health care needs you have are addressed. It's intensive in scope and duration, and it's been very effective. The studies have shown it's been very effective in treating people with complex needs and who need to have that more routine, hands-on approach. And when I say they're literally out in the, with these people 3-4 days a week, that's what they absolutely do. And it is shown to be very, very effective. And if that's a service that you may need as somebody on the moderate spectrum, you can't get it because it's offered no place else, and insurance does not cover it. So it's one of the things that has made us very excited about CCBHC, and there are dozens of other services that fall into that category. So being able to provide 100% of what I can offer to people who are on the mild to moderate spectrum has truly been a game changer. One of the, and I'll go on for my presentation in a second, but one of the examples that I use for it is, say a person was, went to see an oncologist, okay? And the oncologist said, well, yeah, you do have cancer, it's stage 3 right now, but why don't you come back when it's stage 5, and then maybe we'll kind of, start treatments. It's not an indictment of any system that exists right now. For people that do get into the system, you will receive world-class treatment for the illnesses or for the challenges that you're facing. The problem is that we're just not letting enough people into the door the way it's structured. And CCBHC has changed that for everybody. As part of our role as a CCBHC, we don't just operate as a siloed or solo clinic. We have to partner with several different organizations to make sure that we provide the necessary continuum of care for everybody that we treat. So that means interfacing with schools, pharmacies, independent doctors' offices, police departments, hospitals, social service systems. We even have 2 on-site partnerships with federally qualified health centers to provide co-located same-day access to physical health care services right in our offices, and it's a wonderful partnership. When people come in to have their physical health care needs addressed, if that doctor sees that there is some type of behavioral health care issue that's going on with that person, they can refer that person right across the hall in the same instance at the same appointment to talk to one of our therapists that are on staff to say, hey, kind of what's going on, and engage that person in treatment the same day. The reverse happens as well. When we treat people in the community that have behavioral health care issues, oftentimes they don't have a primary care doctor that they see. So they may have physical issues that are going on with them in addition to their behavioral health care needs. And because of our partnership with a primary care provider, when they come in for their appointments, we're able to say, hey, we've noticed you don't have a doctor or a primary care physician on file. We have these services available right here. We'd like you to see the primary care physicians to make sure that physically you're okay as well. So those partnerships are part of the CCBHC spec, and it's something that has become necessary and possible now that CCBHC is here in Michigan. So as I said before, we have to serve everybody, and we do. So that's adults with serious mental illness. That is people with substance use disorders. A lot of people don't know that substance use is part of the mental health care spectrum as well. We service children with severe emotional disturbances and adults and youth with co-occurring diagnoses. I talked before about the plethora of services that we have, which includes targeted case management, crisis services, person-centered planning, a full array of outpatient behavioral health care treatments, as well as peer-directed services as well. So outcomes are something that I think is vitally important to CCBHC and to the health of our overall communities. Since we became a CCBHC in 2018, one of the things that we do is we do screening for people to assess their risk assessment for suicide. For adults, we've seen a 61 increase in compliance with the goals and objectives on persons' suicide risk assessments, and a 91% increase in compliance with that on the children's side. By getting more people in the door, by having more resources available to follow these people in the community and to stay on top of it, we've seen an 86% decrease in the severity of depression and depression symptoms for people who have been screened using our PHQ-9 assessment tools. Additionally, the 60% decrease that I talked about before, the individuals who have been part of the Pathways program that have received this screening, we've seen a 60% decrease in people who've attempted suicides. And for the people that are part of the program, no one has died. No one has died by suicide. This is all because of what CCBHC has allowed us to do. It's allowed organizations like us to be able to spread our wings and to be able to provide that other 90% of services to people who otherwise would not have been able to do that. And I don't have to tell. I don't know how many people on this panel have been touched or know somebody who have been touched by people who have died by suicide. But even a 1% increase matters to those people. Crisis response and law enforcement partnerships. We've all seen on the news, unfortunately, the tragic consequences that can sometimes occur when people who are in crisis engage with the law enforcement system. We know that from our experience that untreated mental health issues do not go untreated. It's usually some form of self-medication. They get entree into the mental health care system through hospital emergency rooms or through the law enforcement system. None of those options are good. None of those options are the preferred way of doing that. With our work through our crisis intervention team, which actually includes ride-alongs with police officers in their cruisers when they're responding to behavioral health emergencies in the community, we've had 4,453 of those encounters where we've actually been able to connect with law enforcement and assist them in the field in dealing with people who have been experiencing mental health crisis. Of those, almost 1,900 have been referred to services, and we're following up with over 1,000 of those individuals on a routine basis. Our officers do the very best job that they can, but it's not a stretch to say that they're not trained and necessarily equipped as well as a fully licensed therapist to be able to deal with those emergencies in the community. So it's something that we do that we've been able to expand as part of CCBHC to help reduce the burden on law enforcement in dealing with that. So CCBHC has a lot of opportunities to improve the overall health of all of our communities through law enforcement, through reducing follow-ups with hospital emergency rooms and that kind of frequent flyer system that we see inside of hospital ERs. Just real quick before I wrap up, for those of you that don't know, whenever a person presents to a hospital emergency room, hospitals have a duty due to the EMTALA rules to make sure, even if they've just seen this person yesterday, to go through the entire screening process, the tests, the time, and all of that to make sure that this person is stable before they can discharge them. It takes time away for those ER docs to devote to other people who might be experiencing actual primary care health crisis. From a financial standpoint, Medicaid and Medicare do not continue to repay hospitals for people who present with the same diagnosis within 30 days. So if I have a medical, if I'm a Medicaid person and I have a mental health illness, but I keep going back to the emergency room 7 times a month. The hospital generally is only going to get paid for that first encounter, okay, if I keep presenting within a 30-day period. So it's an opportunity for us to intervene, take that person, deal with the behavioral health care issue that's causing them to become a frequent flyer of the healthcare system, save time, make ERs more efficient, and for us to actually get to the root cause of the problem that the person is experiencing, that they're seeking in hospital ERs because they really don't know where else to go. So this slide is about how we're able to reach out to veterans and our increased community-based services to veterans, and we also have men and women support groups dedicated to veterans. It's another thing that CCBHC has allowed us to do, and I don't want to gloss over it because it is important, because our veterans are people that often have kind of fallen through the cracks. Hope there's no people from the VA in here, but it's allowed us to be able to focus on their very unique challenges as well. And before Carrie Walker comes up, I do want to say that CCBHC does not need to just be looked at as a program for the state of Michigan. It needs to be looked at as a model of practice, okay? It needs to be something that needs to be expanded, that in the limited time that we've had it, and we've been able to do all of this since 2018. I mean, we're talking about 4 years, okay? And only 1 year as a fully functioning demonstration organization. We've been able to we've been able to produce these outcomes in that short period of time. My colleagues before me, and there were some very good questions from this panel, about crisis services and urgent cares and things like that. I think CCBHC allows us, and I'll say us as a citizen of the state of Michigan, allows us to design and to design a system that can, for the first time, include everyone. We have urgent cares and ERs that the primary care system is fully fleshed out in the United States, particularly in Michigan. You can't go 3 blocks without seeing a private doctor's office or an urgent care or an ER or a hospital or a large physicians group. Those type of resources don't exist for behavioral health care. I would like to see the advent of not, every block or so, but we do need a behavioral health care urgent care system. Crisis teams are great to go out and do the mobile outreach, but we also need a place where families who have loved ones who are experiencing a behavioral health care emergency can come to a place and bring them, just like you can bring a person who might have a broken leg or a broken arm to an ER or an urgent care system. That's one of the gaps that I do see that's in the system. I do think that's something that's worth being fleshed out. So I said a lot, got on the soapbox a little bit, but I'm very passionate about these issues. So that does conclude my presentation.
That's great. Thank you. I don't mind you being on your soapbox. Thank you so much, Mr. Garrett. I'm going to invite Carrie Walker up, who is the president and CEO of the Guidance Center, another CCBHC. We'll get to hear from Mr. Walker, and then if we have time, we'll take a couple of questions. Good morning, Mr. Walker.
Good morning.
Thanks for being here.
Thank you.
Mm-hmm.
Yeah, I appreciate the opportunity. I appreciate having been invited, and it's really a special privilege to be here to share a little bit about what difference CCBHC has made to the Guidance Center over the last 4 years as well. I think that I've seen some of the prior presentations that you've received, and I've got some slides that probably cover the same territory, so I'm going to breeze through some of those things and try to focus on maybe what's unique or different about what I might have to say today. I did want to give you a little background about the Guidance Center. We're located in Wayne County. We're a multi-service nonprofit. We were founded in 1958 by a group of citizens in our community who were concerned about the lack of mental health resources. back in the 50s and 60s, if you had a child with a serious emotional disturbance or developmental disability, the primary source of treatment was a state institution. And the Guidance Center was part of an honorable tradition of child guidance clinics that got started here in the United States. We were beneficiaries at the founding of direct funding from the Department of Mental Health. The department wanted to create community resources, so there were alternatives to out-of-home placement. And so we've continued that tradition. It was natural in 1963 when the Community Mental Health Act was founded that the Guidance Center was part of that and received funding. So we have, over the last 64 years, had children and youth as a core of what we do, but it didn't take our founders long to figure out that if we want to serve youth, children effectively, we need to serve adults. And we added adults to our mission back in the early 60s. And so we've been serving children, youth, adults since that time. But we also have diversified over the years. We're more than just a provider for community mental health. We operate the Children's Advocacy Center in Detroit called Kids Talk. We do over 2,000 forensic interviews a year of children who've been, where there's an allegation of sexual abuse or maltreatment. We're the largest children's advocacy center in the state of Michigan. We do the highest volume of that work. It provides us an opportunity to identify kids who've been traumatized early and help them get the care and treatment that they need for healing and recovery. We operate Head Start centers in southern Wayne County. We also are the juvenile justice provider for Southwest Detroit and southern Wayne County as well. We got interested in CCBHC when it was first started as a bipartisan effort by Senator Stabenow and Roy Blunt in the Senate, part of the Excellence in Mental Health Care Act. What was exciting to me about it was what my colleagues have said, which is that it is a great frustration for people who want to help, who have to turn people away because their problem isn't serious enough or they don't have Medicaid. And the Michigan mental health system over the years became much more Medicaid-oriented as that was used as a source of funding to the exclusion of state general funds. CCBHC is giving us an opportunity to reverse that, to open the door, as my colleagues have said, to people without having to wait until they're in a crisis. And honestly, crisis services are important, but the availability of routine mental health care is probably even more important. And we have the opportunity here in Michigan to expand on that. What is the CCBHC? I think you've got, and so I leave you with that along with what everyone else has mentioned to you. It's transformative in that it allows us to not have to differentiate people by their type of insurance or how serious their problem is. As my colleagues have said, you wouldn't wait to treat cardiac disease until someone had a heart attack, and you wouldn't wait to treat diabetes until someone was in a diabetic coma. But historically here, we've had such a high threshold for eligibility, a hospitalization, a psychotic experience. These are things that are, it's unfortunate that level of threshold has had to have been met in order to qualify, and we need to open the door more broadly. The CCBHC has allowed that. This is just another graphic. I think it was provided by the National Council, again focusing on all the core services that CCBHCs are required to provide. And in Michigan's community mental health system, for the most part, whether you're in a rural area or you're in an urban area like we are, have had these services as part of the array or scope of services. They've just been limited to people on Medicaid, and they've been limited to people with more severe disorders. Michigan, our organizations that are part of the state demonstration were part of an application that took place back in 2017, and Michigan was not selected to be part of the state demonstration at that time. And Senator Stabenow's foresight and response to that was to advocate for expansion grants, for capacity building grants, so that primarily because Michigan was not in the demonstration project that was national. There were 8 states that were in that demonstration. She made a point to make sure that there were capacity building grants that would become available. And so the Guidance Center was successful, along with the organizations that my colleagues represent, in getting expansion grants and demonstrating. But those were grants. They were specific, and in the case of our organization, it allowed us to address some of the services that were underdeveloped within our organization. And for us, because we were a child serving organization in our DNA and our history, our adult services needed to be built out more. And so we were able to use the expansion grant to develop our substance use disorder program, to add peer support specialists in our adult behavioral health program, to add recovery coaches, and even to add a veteran peer. And that was really beneficial. But there are differences between the expansion grant and the demonstration. And I think the point I'd like to, one point I'd like to make today is just that, there are about 38 organizations in the state that have had expansion grants or have them now. Many of them are facing an expiration of those grants. They're not part of the state demonstration. And you have an opportunity, I think, to address that here in Michigan to, one, continue the CCBHC demonstration, but also look to create a pathway so that many of these other organizations that have focused on CCBHC, they've tried to use expansion grants to build their capacity to be a CCBHC, to give them a pathway to participate. Many of those will be rural CMHSPs throughout the state, and many of them will be private providers in counties like Wayne, where the CMH system is largely a network of private providers, and similar with, I believe, Oakland County is similarly situated. Our situation, before the CCBHC was that we were operating on a fee-for-service type of funding for the services that we provided. Our SUD services and services to people with mild to moderate conditions, the reimbursements were not sufficient for us to be able to provide those services. Since the CCBHC, we've been able to address that. We've been able to hire full-time staff to work in our SUD program, and we've been able to open the door to people with mild to moderate conditions. We've been
Mr.
able
Walker,
to, yeah.
just so you know, we have about 5 minutes
Okay.
left. So I just wanted to, we have another committee in here at 10:30. So I
Okay.
just wanted to, I apologize that we don't have more time, but just
Oh,
wanted to.
that's okay. I will, let me move along. So, I think we too have, one of the requirements of the Michigan demonstration has been that each of the CCBHCs, in addition to the core services, needs to offer evidence-based practices, 12 evidence-based practices. One of them is that's included there is a Zero Suicide Initiative, which we've been involved in for the last 4 years. And likewise, as Michael mentioned, at our organization, we have, since implementing these protocols and this initiative, we've had 0 people die by suicide who are active clients at the Guidance Center. So I think the program has outcomes. The demonstration, I think you'll hear more about that from the department as the first year evaluation becomes more well known and is publicized. And again, I would want to emphasize that just the transformative nature of CCBHC. There's been a lot of critiquing of the public mental health system over the last several years. I believe personally it does provide a model. It doesn't solve all the problems in community mental health, but it solves problems in the outpatient continuum of care in community mental health for people with SUD and mental health issues. It might not solve the direct care worker issue in terms of persons with intellectual and developmental disabilities, but it does provide answers and a path forward for reform on the ground where people are getting the service. It's not it does have a financial reform aspect to it in its payment model, but more importantly, the reform is where people come in the door for service, the way they access it, and the type of service they're able to get. As I mentioned, there are only 13 organizations in the state demonstration. It would be wonderful if the legislature could find a way to find more match, to draw down more Medicaid, to expand the CCBHC program. As I mentioned, there's 38 organizations. There's 25 organizations besides the 13 who have SAMHSA grants for CCBHC capacity building. And there are many organizations that don't have those grants that have been working on modifying the way they operate so that they would qualify to become a CCBHC and participate. So I believe that the demand will be there. You will have organizations who are looking forward to providing these services, but they need funding, and we need support from the legislature in order to be able to do that. So, thank you.
Thank you, Mr. Walker. I really appreciate you being here today. Thank you, Mr. Garrett, for being here. Colleagues, if you have questions, what I'd ask is send them to me, and if folks are okay with it, then I can forward them to you, and then we can get them to our entire team here, just because we're short on time. We do have one housekeeping item. So Minority Vice Chair Schmaltz moves to excuse absent members. Thank you so much. There being no further business before the committee, this meeting is adjourned. Thanks, everyone.